Welcome to ICD-10-CM coding for hemolytic disease of a newborn. Hemolysis is the destruction of red blood cells. Hemolytic disease of the newborn, which is also called erythroblastosis fetalis, is a rapid breakdown of a newborn's red blood cells due to isoimmunization. Isoimmunization occurs when fetal blood cells enter the mother's circulation and there is an incompatibility between the antigen status on the mother's and the baby's red blood cells. The mother's immune system views the antigens on the red blood cells as invaders, which causes her immune system to create antibodies that attack and destroy the baby's red blood cells. If you'd like more information regarding the pathophysiology associated with hemolytic disease of the newborn, please visit the URLs shown here. There are several symptoms that may develop in a newborn suggesting the presence of hemolysis. Commonly occurring symptoms include jaundice, anemia, and hepato- or splenomegaly. Jaundice develops because the rapid destruction of red blood cells creates more bilirubin than the liver can process. The bilirubin leaks into the blood and tissues, causing yellowing of the skin and mucous membranes. Anemia is caused by the rapid loss of red blood cells, and hepato- and splenomegaly are caused by the body's attempt to quickly make new red blood cells to replace those being destroyed. It's important to note that these conditions may have other causes, so while their presence is suggestive of hemolytic disease, they are not a definitive confirmation of this diagnosis. The most common cause of isoimmunization and newborn hemolytic disease is blood group incompatibility, related to the presence or absence of antigens on red blood cells, specifically Rh or rhesus factor incompatibility or ABO incompatibility. Human blood comes in 4 types: A, B, AB, and O. Type A blood has type A antigens on its cells. Type B blood has type B antigens. This means that if a type A patient's blood intermingles with type B blood, the patient's immune system will view the type B antigens as a threat, leading to the creation of anti-B antibodies in the type A plasma, which will attack and destroy the type B blood cells. The converse is true when a type B patient's blood intermingles with type A blood. Patients with blood type AB have both A and B antigens on their red blood cells. Patients with type O blood have no antigens on theirs. When a type AB patient's blood is intermingled with any other blood type, the immune system does not react, because it recognizes both the A and B antigens as normal. But if a type O patient's blood intermingles with any other blood type, the immune system will react because it considers cells with A and or B antigens as foreign. ABO incompatibility occurs when a mother has type O blood, meaning she has no A or B antigens on her red blood cells, and the baby is blood type A, B, or AB. If the mother and baby's blood intermingle, the mother's immune system will create A and B antibodies that will attack the A and or B antigens on the baby's red blood cells, leading to hemolysis. Rh factor is another type of antigen found on red blood cells. People who have the antigen are Rh positive, and people without the antigen are Rh negative. Rh factor is distinct from blood type. People of any blood type can be Rh positive or Rh negative. Rh incompatibility arises when an Rh negative mother is pregnant with an Rh positive baby. If the baby's red blood cells enter the mother's bloodstream, the mother's immune system will interpret the Rh antigen on the baby's cells as foreign and will create antibodies against the baby's blood, causing isoimmunization. Determining the correct ICD-10-CM code to report hemolytic disease of the newborn is pretty straightforward. The alphabetic index provides multiple main and subterms leading to codes for a documented diagnosis of hemolytic disease or isoimmunization of newborn due to or with ABO or RH incompatibility. For these diagnoses, the index directs assignment of codes from category P55, hemolytic disease of newborn, with a fourth character of 0 for RH isoimmunization of newborn or 1 for isoimmunization of newborn due to ABO incompatibility. The index also supplies direction related to coding for jaundice and anemia associated with hemolytic disease of the newborn. If documentation supports jaundice or anemia is due to ABO or RH antibodies, maternal fetal incompatibility, or isoimmunization, the index directs assignment of codes P55.0, RH isoimmunization of newborn, or P55.1, ABO isoimmunization of newborn. A separate code for jaundice or anemia is not assigned. This is consistent with ICD-10-CM General Coding Guideline 1.B.5, signs and symptoms that are associated routinely with a disease process should not be assigned as additional codes unless otherwise instructed by the classification. Part of the clinical workup for determining a diagnosis of blood group incompatibility is a Coombs or antiglobulin test. This test detects the presence of antibodies that attack red blood cells. A direct Coombs test is used on newborns to see if their red blood cells have antibodies attached that may lead to their destruction. An indirect test looks for the presence of antibodies in the mother's blood, suggesting a possible reaction to incompatible non-maternal blood. It's important to remember that a direct Coombs test is simply a lab test to establish the presence of antibodies on red blood cells. The test does not identify the type of antibody or what its presence means. Additional workup is needed to make a definitive diagnosis of the patient's condition, which may take place in the outpatient setting after the newborn is discharged from the delivery admission. Documentation of a positive result alone on a Coombs test does not support assignment of codes from category P55. Physician diagnosis will generally be based on both a positive result on blood testing and additional clinical criteria. These could include spherocytes or other findings on a blood smear, hyperbilirubinemia, or other relevant clinical findings. Codes from category P55 are only assigned when supported by a documented diagnosis of hemolytic disease, isoimmunization, or ABO or RH incompatibility. However, documentation of a positive result on a Coombs test can and should be coded when it is part of a newborn's clinical workup. Although documentation of a positive Coombs test is not required for a diagnosis of newborn hemolytic disease to be assigned. There is not a distinct code in ICD-10-CM for a positive Coombs test. A positive Coombs test identifies an abnormality in the patient's blood. By following the terms abnormality, chemistry, blood, and specified NEC, the index directs assignment of code R79.89, other specified abnormal findings of blood chemistry. This is the code that should be reported for documentation of a positive Coombs test. A word of caution. It might be tempting to assign code P09.3, abnormal findings on neonatal screening for congenital hematologic disorders, for a positive Coombs result. However, codes from category P09 are used to report failure on screening tests from the recommended Uniform Screening Panel, which is a list of universal newborn screening exams recommended by the Department of Health and Human Services. A Coombs test is not included in this list and is merely a lab test to detect incompatibility rather than a true screening for a definitive condition. Thanks for watching. Health Information Associates is committed to providing educational products that help coders be their best. So be sure to check out the other presentations on the HIA YouTube channel, as well as our full catalog of offerings at hialearn.com. Happy coding!